we're going to go over all this ad nauseum. So let's just kind of recap what we went over last week at the very end. So you have two major like umbrellas of the endocrine system, right? You have the more complex types that involve multiple organs and two or more hormones. And then you have the more simple type hormonal pathways. So simple hormones, just one hormone, one activity, one action. So you have, for instance, atrial natriuretic peptide from the heart. It senses, for instance, when you have too much blood volume. And so it's saying, let's try to reduce the blood volume so you can reduce the blood pressure. And so what it does, you excrete sodium, and then water follows solutes, right? So then that thereby reduces your blood volume, thereby reducing the blood pressure. Insulin, another good example of that. You have too high levels of glucose in your system. Insulin gets released from your beta islet cells in your pancreas, and then insulin allows your cells to take up all that glucose, thereby reducing your blood sugar levels to more reasonable values. More complex systems, like I said, two or more organs, as well as two or more hormones. So the like stereotypical example of that is the hypothalamus pituitary axis, right? And the end organs can be things like your thyroid your thyroid gland. So if like thyroid stimulating hormone gets released from your pituitary, it's going to activate your thyroid into producing and releasing thyroid hormone, aka T3 or T4. T4 is going to be the most that's produced. Then T3 is going to be what gets converted in your liver. And then other organs can also be your adrenals. And we're going to talk about the adrenals next week in greater detail, because there's different levels of the adrenals. You have your adrenal medulla. That's going to be mostly associated with the chromaffin cells that produce norepinephrine and epinephrine. That's going to be implicated in the sympathetic nerve activation pathway, right? So fight and flight. And then there's going to be different levels of your adrenal cortex. There's 3, and they're going to be involved in sex hormones, stress hormones, and salt, right? So aldosterone is a good example of that. So that's going to be much more complex. You first get a releasing hormone signal from your hypothalamus that then is going to stimulate secreting hormones from your pituitary gland. And then the pituitary gland, whatever that target organ is, say, for instance, the adrenal cortex, then you could have something like adrenocorticotropin hormone getting released to release cortisol, right? So those are going to be a couple of good examples of more complex systems. By the way, can you guys all hear me in the back over there? Okay, cool. So that's a summary of a couple of good examples of the more simple versus complex systems. And then these were the quizzes that we did last week. And we're going to finish up today's lecture with 8 different questions at the end. So we'll do that around 4 o'clock-ish towards the end of class. So here are all the different hormones that you need to be familiar with. All the ones at the top are going to be associated with your hypothalamus, okay? So your hypothalamus is going to be associated with releasing and inhibitory hormones. So all the way to the right, that's gonadotropin hormone, releasing hormone. Tropin just means something that's going to activate like secretions, right? So it's going to activate. That's what tropins mean. When you hear that suffix, that's going to be something that allows for other things to get stimulated. And then we're going to talk about like statin. So like somatostatin, those are going to be inhibitory. So if you hear the term statin, for instance, like your statin drugs, like atorvastatin, that help to reduce cholesterol, those inhibit cholesterol levels. So if you hear the term somatostatin, that's going to be growth hormone inhibiting hormone. So if you hear that term statin, that means you're trying to bring something down. CRH is corticotropin releasing hormone. TRH is thyroid releasing hormone. PRH is prolactin releasing hormone, and et cetera, right? So it's going to be releasing hormones or also inhibiting hormones that are going to be associated with your hypothalamus. Then moving down a level, you have your pituitary gland. And your pituitary gland is going to be subdivided into 2 major sections. You have your anterior pituitary, that's going to be your adenohypophyseal system. And then the posterior pituitary is going to be your neurohypophysis. Okay? So adeno just means glandular, and then we all know what neuro means, right? So as far as your adenohypophysis, follicle-stimulating hormone or luteinizing hormone is going to be associated with sex hormones, right? It's going to stimulate the gonads, whether it's the testes or the ovaries, to go ahead and do their thing. ACTH is adrenocorticotropic hormone, and that's going to help release things like cortisol from the adrenal cortex. And then TSH, thyroid stimulating hormone, not to be confused with thyroid releasing hormone. The stimulating hormone is going to help the thyroid release T3, T4. And then prolactin is going to go activate the mammary glands to produce milk, right, during breastfeeding. Growth hormone is going to be activated in the liver to turn into insulin-like growth hormone, and that's going to have effects throughout the body. And then you get to your neurohypophysis, okay? So the neurohypophyseal system is going to be the posterior pituitary, and there's only two types of hormones associated with that. It's going to be oxytocin, okay, and antidiuretic hormone. Now, oxytocin is going to be associated, like we talked about last week, it's going to be associated with like feelings of pair bonding, right? So whenever, you have intimate contact, whenever like a mom hears a child crying, it's going to stimulate lactation. It actually, oxytocin and prolactin both kind of work together, right? As well as during childbirth, oxytocin is going to be involved in that positive feedback system when the baby's about to be born. It's going to be pushing against the cervix. While you have that pressure against the cervix and pressure against the uterus, that's going to release more oxytocin, and it's going to increase contractions in the uterus during childbirth and labor. Okay, so that's what oxytocin is involved in. Antidiuretic hormone is going to be the way in which your body conserves water, right? Diuresis, like when you take a diuretic hormone or a diuretic drug, right? Like Lasix, things like that. Those are going to make you urinate, right? Antidiuresis is going to prevent urination. So in other words, if you're thirsty, you're dehydrated, you go on a long hike, through the desert, all of a sudden you don't have any water, ADH is going to kick in, so it can help preserve or prevent fluid loss. So make sure you know these different hormones, where they come from, where they originate from. And then a side note about ADH and oxytocin, those are going to be produced by the hypothalamus. They're not produced by the pituitary. They are, however, stored in the posterior pituitary. Okay? So they get produced in the hypothalamus, they get released into the posterior pituitary, and then they get activated depending on the conditions. Okay? So this is the diencephalon. So your brain is going to be subdivided into different sections. You have the mesencephalon. Okay, so that's going to be like midbrain, pons, medulla. Diencephalon is going to involve like limbic system. It's going to involve the corpus callosum. It's going to involve what is it called? Sorry, I had a brain fart. I'll get back to that in a second. But a lot of like your basic hormones are going to be released from your diencephalon. And then the telencephalon is going to be like your cerebral cortex. So it's going to be like higher order brain functioning. Sorry, amygdala and hippocampus. That's all going to be part of the diencephalon. So the hippocampus is involved in things like memory, retention. Amygdala is going to be associated with like fear response. Think about like that whole fight and flight. The amygdala is going to be implicated in that as well. Okay? So this is the diencephalon. The main glands that we're going to be looking at are going to be not the thalamus particularly, but below the thalamus. The hypothalamus, which is going to be this region right over here. So this is the thalamus. It's going to be surrounded by all your ventricles. So you have like your third ventricles, for instance, fourth ventricle. Your thalamus is going to be surrounded by the third ventricle. Then the pineal gland is going to be like more of the posterior region in the diencephalon. And then you have the hypothalamus, which is going to be this region right here. Then this guy right here, that's the optic chiasm. So your optic nerve, cranial nerve number 2, is going to go from your eyes, and then it's going to cross at the optic chiasm. And it's going to cross at the optic chiasm anterior to your pituitary gland. I'm going to talk about why that's important later, because there's going to be certain conditions that affect the pituitary gland that can actually affect your vision, just because of the proximity of your optic chiasm, optic nerve to the pituitary gland. So we'll talk about that at the very end of today's lecture. Speaking of which, did you guys get the updated, this is like the updated version of chapter 17. You guys all got that? Okay. I know you guys like to take notes into the margins and stuff, so I'll try to get the final version of the lecture slides as promptly as possible because of that. So anyways. And then the infundibulum. The infundibulum, that term means funnel, okay? So the infundibulum is going to be sort of like the stalk that holds on to the pituitary gland, okay? Now, the reason why in this image over here of the brain, why there's no pituitary gland right there, why do you guys think that the pituitary gland's not in this picture? What's up? Yeah, exactly. So once you remove the brain, because it's attached to the stella tunica, it gets ripped off. So the moment you remove the brain, you're inadvertently going to remove the pituitary gland. So it kind of gets stuck in there, unfortunately. So you're not going to see it. But you do see the infundibulum, which is going to be kind of like the root of the pituitary gland. Cool. Some other things here. Let's see. Fornix, that's going to be associated with a little bit of like memory retention. Frontal lobe, that's higher executive function. Corpus callosum connects both of the hemispheres of the brain, cerebral hemispheres, but that's not going to be important for today's lecture. Those are just some other interesting anatomical features. So let's talk about the hypothalamus. Okay, so the hypothalamus, that's going to be the region of your brain in the diencephalon that's going to be associated with releasing hormones as well as inhibitory hormones. And this image, they didn't have the hypothalamus highlighted for you, so I highlighted right there. It's going to be this little red blip right there. B right there, that's the thalamus, okay? So the thalamus is going to be directly above. Then it goes thalamus, hypothalamus, and then pituitary gland. So you can see it there because it's an MRI image. The brain is still intact in the person's skull, so you can still see it there. So as I said, releasing hormones and inhibitory hormones. A good example of those inhibitory hormones would be like growth hormone, inhibitory hormone. There's also growth hormone, releasing hormone. So those all kind of act in balance with each other. Those inhibitory hormones, sometimes you'll refer to them as like statin hormones. So somatostatin is going to be another term for those inhibitory type hormones. Cool. Moving forward. All right, so here's a recap on that. So you have your releasing hormones. So growth hormone, releasing hormone, right? So it's going to affect the ability for growth hormone to get released. And then you have growth hormone, inhibitory hormone, also known as somatostatin. So let's talk about some other releasing hormones versus inhibitory hormones. So remember we had that chart back here. It doesn't really give you all the inhibitory hormones, but just know that some of these are going to have inhibitory hormones associated with them. But over here it gives you some good examples of those inhibitory versus releasing hormones. So thyrotropin releasing hormone, okay? Corticotropin releasing hormone. Then growth hormone inhibiting hormone, which also has a releasing hormone counterpart as well. And then this up here, this is really important for you guys to keep in mind as far as antidiuretic hormone and oxytocin. Just make sure you guys know that both of those are going to be formed in the hypothalamus and then stored in the posterior pituitary. And then there's also going to be neuroendocrine reflexes associated with the hypothalamus as well. So there's going to be the sympathetic region in the hypothalamus that actually stimulates that adrenal medulla, right, during sympathetic activation, right? So that fight and flight type activation. So you're going to see release of both norepinephrine as well as epinephrine. Right. All right, and then as far as the different nuclei that are going to be associated with the release of oxytocin and antidiuretic hormone, we're going to get into that in a second here. So let me actually just fast forward. I'll get back to that slide. So you have two different nuclei that are going to be found in the hypothalamus that are associated with either oxytocin or antidiuretic hormone. So in the front, on the anterior side, you're going to have the supraoptic nuclei. The reason why it's called supraoptic is because it's directly above the optic chiasm. Okay, so the supraoptic nuclei is associated with antidiuretic hormone specifically. Okay, then when you go further back behind that, a little bit more posterior, you have the paraventricular nuclei. The reason why it's called paraventricular, you guys remember that term para, like paracrine? That means it's adjacent to. So the paraventricular nuclei are adjacent to the ventricles, the third ventricle. And so that nucleus is going to be associated specifically with oxytocin. All right. So one way that you can maybe remember this is that the one in the front starts with A. A is the first letter in the alphabet, antidiuretic hormone. And the one behind is going to be starting with O, so oxytocin. So that might help you remember which one comes from where. And then you have your neurosecretory neurons. So let's go back real quick here to the neurosecretory hormone. So this is what's going to happen over here. So the neurosecretory hormones are going to be even posterior to that. So it's a little bit further behind the paraventricular nucleus. This is where you're going to see the autonomic activation of the sympathetic pathway. Okay, so that's going to be autonomic activation of the adrenal medulla during fight and flight. Okay, so if you get chased by a lion, I don't know why you would get chased by a lion, but if you did, this is what would get activated, so you can run away. Probably unsuccessfully, but still, you at least tried. In terms of blood supply, it's kind of important to understand how the hypophyseal portal system works. So you have a couple different vessels that are coming in. You have the superior hypophyseal artery, and that's going to be providing circulation to portions of the hypothalamus going down into the anterior pituitary. And then you have the inferior hypophyseal artery, which is going to provide blood to the posterior pituitary. Moving on. Cool. Any questions so far? All right. So here's another summary of all that. So in the hypothalamus, that's where you're going to have all these different releasing hormones, inhibitory hormones, so growth hormone, releasing hormone, GH, IH, etc. Moving forward. Cool. So let's go into a little case presentation. Don't fast forward in your lecture slides because you guys have the information. Let's just kind of work through this without cheating, okay? So if you guys want to go ahead and partner up in a couple groups, let's do like 4 groups. You guys can all be one group. Half of this section can be one group. Half of this section can be a group, and that section can be another group. And then just read through the case presentation and kind of try to work through why some of these different symptoms might be taking place. Okay? So I'll give you guys about like 3 or 4 minutes. And instead of looking at the slides, maybe you can even do a little Google search, right? So you can see what's going on, like the mechanisms of what's happening in this case. Have at it. Start meeting your neighbors, okay? Be friends with each other. All right, y'all. Okay, so let's start with you guys over here. What do you guys think? What do you think is going on? What are the signs and symptoms taking place? Does it sound like that she has a hormonal imbalance all of a sudden? Yeah, she totally has a hormonal imbalance. So she has inability to produce breast milk. What hormone is implicated in that? Prolactin, good. She has irregular absent periods. What's associated with that? FSH, LH, so follicle stimulating hormone would be a good example of that. Hot flashes. Who gets hot flashes? Women who are going through menopause, right? Okay, so she's not able to produce her like sex hormones. Also, decreased sex drive. That's going to be hormonally mediated. Fatigue, low blood pressure, and hair loss. Let's go to hair loss. What's happening with hair loss? What hormone is often associated with hair loss? You guys. Take a guess. You guys know off the top of your head which one's hair loss? No? Thyroid hormone. So if you have imbalance of your thyroid hormone, it's often going to cause hair loss. So alopecia. Okay, so that's hair loss. Kind of a sucky condition, especially for a lady, right? And then let's see. What about blood pressure? What are some of the hormones that regulate blood pressure? You guys? ADH, good. Antidiuretic hormone is going to help regulate blood pressure. Also, when you get down into like your adrenals, aldosterone is going to help regulate blood pressure as well. Okay, so if you had low blood pressure, aldosterone will help to conserve salt and ions so that you can increase your blood pressure. So if she has low blood pressure, she might not be producing aldosterone in adequate amounts. Okay, so in other words, does it sound like a lot of her hormones are off? It's like almost all of her hormones are not working well at all. So what do you think happened? So what's the key giveaway over here? Any volunteers? I asked you guys, but anyone else can volunteer what they think. What's the key giveaway here? What happened? You back there. Well, yes, definitely something wrong with her pituitary gland. Why? She did what? Uh-huh. It's more so what happened during birth. She lost, look at this part right here. Right here. Extensive bleeding during labor and delivery. L&D means labor and delivery. So while she was giving birth, she lost a lot of blood. So what do you think might have happened to her pituitary gland when she lost a lot of blood? It didn't have enough blood. It didn't have enough oxygen. In other words, she underwent pituitary necrosis. So her pituitary gland literally just died. And so that's called Sheehan syndrome. It's a very rare condition, thank God, but it happens. Some women get this. When they're delivering, they bleed too much, right? And so not enough blood is able to go to the pituitary gland. And remember, you saw those two little vessels, right? Little tiny capillaries, part of that hypophyseal like portal system. So not really much in terms of like a blood supply. So just a small disruption of blood can actually result in like necrosis of the pituitary gland. So Sheehan syndrome is going to result in a lot of different things. They call it panhypopituitarism. Okay, so pan means all across the board, right? So in other words, like all of her pituitary hormones have been basically destroyed. She's not able to produce any of them. You can get oligomenorrhea, which means infrequent menses, so it's going to affect the menstrual cycle. You can throw the patient directly into menopause because of inability to produce any of those like sex hormones. Cortisol levels and adrenal insufficiency can also happen as a result of this. The hair loss is mostly going to be associated with like thyroid, right? So you're not getting that thyroid stimulating hormone produced. So you're not able to actually produce any thyroid hormones at the level of the thyroid gland. And then inability to produce breast milk, some of you said, prolactin, which is perfect. And then the hot flashes, that's all going to be associated with menopause. And then also because of some of the sex hormones being affected, you can get thinning of the vaginal lining. That's a very common theme for a lot of like postmenopausal women. They get thinning of the vaginal walls. Very uncomfortable. And then what else? Fatigue. Fatigue is going to be associated with the inability to like develop those like stress hormones, cortisol, because cortisol, as we're going to talk about in a little bit, helps to like release glucose in the system. Fatigue also, if you're not able to produce thyroid hormone, you're going to be hypothyroid. And hypothyroid people are going to be really tired, very fatigued and lethargic. And then weight gain. If you're fatigued and lethargic, chances are you're going to start putting on weight, right? So those are all going to be signs and symptoms of Sheehan syndrome. So let's talk about the pituitary gland then in a little bit more detail. So the pituitary gland is the master gland of the entire body, right? It's going to be implicated in many different areas of physiological function. It's going to be associated with sex and reproduction, right? So follicle stimulating hormone, luteinizing hormone all going to be associated with stimulating the gonads as well as the ovaries in doing multiple different things. Thyroid gland, adrenals, kidneys, things like that. So these are all going to be associated with the pituitary gland. So one of you had already mentioned that if you remove the brain, the pituitary gland is going to be left behind. That's because it gets stuck right in here, the sella turcica. And that's going to be all part of, like, enveloped into a dural sheet. And that dural sheet is basically going to keep it in place, right? So if you guys recall the different layers of, like, the dura, right? So you have the dura mater, pia mater, things like that. So it's all going to be kept within the dural sheet. And then it's going to be associated with the infundibulum, right? So the infundibulum is that funnel, right? So it's kind of like the stalk that helps to support the pituitary gland. And all that's going to be directly inferior to the hypothalamus. And then there's going to be 9 major hormones that are associated with the pituitary gland, 7 of which are going to be found and synthesized in the anterior pituitary, 2 of which are going to be stored in the posterior pituitary. So these are all the different hormones that are associated with the different regions of the pituitary. Anterior, so it's going to be TSH, ACTH, GH, prolactin, MSH, which is melanocyte stimulating hormone. So that's what stimulates the melanocytes in your skin to create pigmentation. Follicle stimulating hormone and luteinizing hormone. The thing about MSH is a little bit different than the other hormones because the MSH is going to be specifically synthesized in the pars intermedia. So this is the anterior or adenohypophysis, the posterior or the neurohypophysis, and then right in the middle is going to be that pars intermedia. And the pars intermedia is specifically where you see melanocyte stimulating hormone being produced. And then the posterior pituitary, that's going to be your neurohypophysis. It's going to be ADH and oxytocin. So those are the most important hormones that are going to be associated with the pituitary. And then, as I mentioned earlier, if you see tropin as a suffix, tropin means stimulating, okay? And then statin is going to be inhibitory. So if you hear that term somatostatin, that's going to inhibit the ability for, like, growth hormone, for instance, to do its thing. Oh yeah, and by the way, side note, you see statin right here, somatostatin, that's going to be associated with growth hormone. Prolactin's a little bit different. So there's actually prolactin inhibitory hormone. What it actually is, it's dopamine. So if you have dopamine in excess in a person's body while they're, like, trying to produce breast milk, if they're lactating, then dopamine is actually going to reduce the ability for prolactin to actually produce milk at the mammary glands. So we already kind of went over all this here. So you have antidiuretic hormone associated with the anterior portion, right, the supraoptic nucleus. You have your paraventricular nuclei, which produces oxytocin. And then you have your neurosecretory neurons that are going to be sending off preganglionic nerve fibers from the sympathetic system into the adrenal medulla to release norepinephrine and epinephrine. Cool. So let's talk a little bit more about oxytocin and ADH, antidiuretic hormone. So oxytocin, the 2 major things that oxytocin is going to be associated with is breast milk ejection, and then as well as uterine contraction during labor, so labor and delivery. And then antidiuretic hormone is going to be going off into your kidneys, okay, so the renal tubules, and then that's what allows for decreased urine production, right? So it's going to increase, like, urine retention, all right? Moving on. We kind of talked about that already. Here's a fun fact. So when you are thirsty, that means you've been dehydrated for a while already. So as your plasma osmolarity starts going up and increasing, all of a sudden antidiuretic hormone is going to start getting released. So it's going to start getting released early on to try to conserve your water. Then once you actually start getting really thirsty, that means that you've probably been dehydrated for a little while already, okay? So then thirst actually kicks in a little bit later. And then in terms of oxytocin, so oxytocin versus prolactin. So as I mentioned earlier in the previous slide, oxytocin is going to be specifically associated with the ejection of milk. But the actual production of milk is going to be associated with prolactin. But they basically work in concert together. The other thing about oxytocin is that oxytocin also gets stimulated, not just with like the actual suckling, but also like when a mom hears her baby cry, oxytocin starts getting released, not only to like encourage her to go over there, tend to her child, but also to help produce breast milk as well. So it all kind of works together. So here's that on the left here, prolactin versus oxytocin. And then it's going to be a positive feedback. That's what this blue arrow over here is. That's going to be a positive feedback system. As the child is suckling, that's going to be a positive feedback to encourage the production and release of both of those hormones. Now, similar with a positive feedback system, you're going to get that similar type of positive feedback system during labor and delivery. So let's go through it here in the cycle. So you have nerve impulses, right? They're going to be transmitted from the cervix. As the baby is pressing up against the cervix, causing an increased amount of intrauterine pressure, you're going to see brain stimulation that helps to release oxytocin during that process. As oxytocin gets released, it's going to be going to the blood system, right, because it's part of the endocrine system, and then it's going to stimulate more uterine contractions. And as you stimulate more uterine contractions, you're increasing the pressure yet again on the cervix. And that whole process keeps going until finally the child gets delivered. Cool. So any questions on those hormones so far? No questions? Awesome. All right. So this here's just a reiteration of all those hormones that are associated with the anterior pituitary. So just trying to nail this in because these are all very important for you to know which ones go where. So let's go through it all over again. So growth hormone, sometimes referred to as human growth hormone, same thing. You can also see how growth hormone changes in the liver. When growth hormone gets released, once it goes to the liver, it gets converted into insulin-like growth hormone. So you're going to see IGH. But when you see GH, you're just thinking growth hormone. All of which does very similar things. It helps, increase production of like muscles, things like that. Then thyroid stimulating hormone, right? Thyroid releasing hormone comes from the hypothalamus. Prolactin, and then adrenocorticotropic hormone, right? That helps to release cortisol in the end. Follicle stimulating hormone, luteinizing hormone. We're going to talk about those two in particular later on when we get into like reproduction, because those are going to be associated with mostly reproduction. And then melanocyte stimulating hormone. Where do you find melanocyte stimulating hormone again? Pars intermedia. Awesome. All right, so let's talk briefly about cortisol. Is a lot of cortisol in your body a good thing? What's cortisol associated with? Stress, yeah. So if you're all like really stressed out all the time, it tends to, over time, degrade different systems in your body. One of the major reasons that happens is because cortisol helps to release like glucose. And glucose in excess is not good, right? Glucose, one of my colleagues, Dr. Jackson, he likes to refer to glucose as like being like little shards of glass going through your body. And it's true because glucose wreaks havoc on so much of your body. It can destroy your kidneys, right? It can cause like glomerular nephropathy. It can cause blindness, right? It can cause retinopathy. It can cause eventually like peripheral neuropathy, so it destroys your nerves. It can also destroy vasculature, right? So all of your capillary beds start getting degraded, so you can get like poor vascularization, peripheral vascular issues. So blood sugar is really devastating because of those things, right? So that's why we want to make sure that our diabetic patients are taking either their drugs or trying to maintain a healthy, diet and lifestyle. But cortisol can be good if you're this zebra over here and getting chased by this lion, or just in general, like if you need like stimulation to undergo any different types of activities, right? Cortisol is going to be important in giving you the energy and the wherewithal to be able to conduct your day-to-day activities. It also helps to repair different types of tissues under certain circumstances. That's one thing. And cortisol also, when you're in a situation of like fight and flight, there's going to be certain things that you don't want your body to be doing, right? Things that would be a waste of time, right? That's why sympathetic versus parasympathetic. Sympathetic is stimulation. Parasympathetic is rest and digest. You don't want to be resting and digesting when you're getting chased by a lion, right? Cortisol is kind of a similar thing. Cortisol will help to reduce the activation of different systems that are not essential at that particular moment in time. Cool. So here is the the hypothalamus, pituitary, adrenal system. So in your hypothalamus, remember we have releasing hormones and inhibiting hormones. In your hypothalamus, you're going to have CRH. So it's corticotropic releasing hormone. Once CRH gets released from the hypothalamus, it's going to go to the anterior pituitary, also known as the adenohypophysis, and it's going to help release or stimulate ACTH, so adrenocorticotropic hormone. And then once ACTH gets its way down to the adrenal cortex, then it's going to release cortisol. Okay, so that's going to be the way in which cortisol gets released. Then once cortisol levels go really high, then that's going to create a negative feedback loop because you don't want to continually release cortisol, right? So it's going to eventually turn off both the hypothalamus as well as the pituitary gland. So it enacts a negative feedback loop on both of those glands. Cool. So let's do another case presentation. And like I said, just like last time, let's not go forward in the lecture slide so you see what we're talking about. Let's do the same groups again. So get chatting with your neighbors about this case presentation. I don't know who the heck this guy is, but this is his case presentation. So I'm just kidding. You guys know who this is, right? It's a little bit before our time. It's before my time too, even though I'm an old fogey. So pair up and talk about this case presentation. It's a true story, by the way. I'm not violating HIPAA because this is very public. There we go. All right, beautiful. All right, let's talk about this case. So who is this guy? John F. Kennedy, and what does he have? Okay, so let's talk about the symptoms. So let's talk about the bronzing of the skin. Is kind of like a little tougher to figure out, but once you like do the association of bronzing with the skin, you'll know this condition like forever. And I'll give you a good way to remember it as well. But let's talk about the dizziness upon standing, okay, and then the fatigue. What hormone were we just talking about that's associated with like activating like sugar, glucose release, things like that? What? Cortisol, right. So do you think that President Kennedy has a like less cortisol than probably you and I do? Yeah. And then he also has dizziness. So it means that he's probably getting a little like low blood pressure. What's associated with that? Remember we talked about that? Huh? TSH, sort of. What's the other one that maintains blood pressure? That helps to maintain blood pressure. Huh? ADH is one of them. What's the other one? Aldosterone. Cool. So his condition specifically reduces cortisol, and in some patients, it also reduces aldosterone levels. Now, the bronzing of the skin. What causes skin pigmentation? Melanocytes, right? Melanocytes release melanin, which provides pigmentation to the skin. So John F. Kennedy had what we call Addison's disease. So back when he was 30 years old, he actually got diagnosed with this. A really interesting little bit of history. This is a total digression. But when he was debating President Nixon for presidency back in I think it was 1962, something like that, everybody on TV, like when they were watching them debate, they thought that Nixon just kind of looked like an old fuddy-duddy. He was just kind of pale, kind of grumpy. And then here's, John F. Kennedy looking all young and spry and nice and tan. Everyone's like, oh, he went to the beach and had a tan. No, he actually had Addison's disease. That's why he looked tan. So he looked really healthy. But he actually had a lot of underlying health conditions. So Addison's disease is a pretty severe condition. Later on, he actually he developed hypothyroidism. So I forget what type exactly, but this was like this is when he was 30. Then when he was like a little bit older than that, it was like 1955. This was 1947. 1955 is when he got diagnosed with like hypothyroidism. So eventually his thyroid started to like get affected as well. So lots of underlying stuff going on. So the darkening of the skin, the melanocytes, is actually not associated with the melanocyte stimulating hormone, the MSH. It's associated with the ACTH. So if you have if you have reduced cortisol levels, right, as well as reduced aldosterone, what's your HPO axis, the hypothalamus pituitary organ axis going to do? It's going to try to compensate for that, right? Because if you have really low cortisol levels, you don't have enough cortisol. What's your HP axis going to do? Hypothalamus is going to try to release cortisol-releasing hormone, right, CRH, and then it's going to try to stimulate the release of ACTH, right, so adrenocorticotropic hormone. And then all of a sudden you have too much of the ACTH. It's not really doing anything because your adrenal glands aren't producing cortisol. So this is actually called primary adrenal insufficiency. Okay? So primary adrenal insufficiency. Now, in other words, your hypothalamus and your pituitary gland are starting to go into high gear, and because of that, ACTH is being released, and ACTH can actually have direct effect on melanocytes. And so the melanocytes get activated, they start producing melanin, and that's why these patients get the bronzing of the skin. Usually, before they become symptomatic, the bronzing of the skin is what happens first. So, I don't know. Anyways, and then aldosterone is going to affect sodium, right? So aldosterone is what helps to retain sodium, right? And so if you do not produce enough aldosterone, you're not retaining enough sodium, you're urinating more frequently, and then your blood pressure goes down. That's why you get like dizziness, lightheadedness, fatigue, things like that. Okay? Did you guys know that about JFK, by the way? No? Cool. Learn something new every day, right? This is what happens if Addison's disease goes haywire. It can happen. It's called an adrenal crisis. So this is what would happen. Let's follow some of the things that are going on here. So adrenal gland not functioning, sorry. So up here is going to be cortisol, down here is going to be aldosterone. Without proper cortisol release, your liver is going to reduce functioning. Because of that, you're going to get reduction in glucose release. So you have low blood sugar, and extremely low blood sugar, you can go into coma and death from that. A really good way not a good way. That was a really dark way to say it. I had a patient when I was working in psychiatry. She took an overdose of insulin to try to kill herself. She almost did. She was very close to death. She was lucky to be alive. She was actually a nurse too. She got really depressed in practice. I think she lost her job or something, and then she took a fatal dose of insulin. She was resuscitated, thank God. But some people commit suicide by taking way too much insulin. And the reason why that happens is because all of a sudden your blood sugar tanks completely, and that can result in brain death and coma. It's a very effective way to die. I've actually heard of people who, there was a guy who was getting insulin from his wife, and he had dementia, and he had an insulin overdose, and it was thought that the wife was the one that actually did that to collect insurance money from the husband who had dementia. What's up? That is awful, really. When was this a recent story, or is this? What's it called? The what? The Good Nurse? All right. Yeah, that's pretty dark. What was her justification? Was she just like tired of humanity? Yeah, I would imagine that he had mental health issues. Yeah. So, anyways, I'll have to check that out. The Good Nurse. I'll make note of it. I'll put it on my list of films to watch. Digestive enzymes. Sorry. If you're not producing digestive enzymes, you can get a lot of nausea and vomiting for that. Nausea and vomiting is going to reduce in fluid loss, right? Now let's go down to aldosterone. So your kidneys are not maintaining water, right? So you're losing sodium and you're losing water. That might affect your heart, so you're going to have decreased cardiac output. You're going to have a reduction in like left ventricular, what's it called, ejection fraction. Then you have low fluid volume from the vomiting. Then you have low blood pressure. That can put you directly into shock, right? And then when you go into shock, you can have a fatal arrhythmia as a result. You can go into like VTAC, ventricular tachycardia, and that's another way that you could die from that. So in other words, Addison's disease is no joke. So patients with Addison's disease, even though they look, nice, healthy, and tan, they run the risk of getting an adrenal crisis in the end. So, all right, so let's talk a little bit about glucose. So we talked a little bit about glucose associated with like cortisol release, but glucose can also be associated with growth hormone release as well. So let's go through this axis. So remember the hypothalamus releasing and inhibiting hormones, okay? So if you have low glucose in your body, then that's going to stimulate in your hypothalamus growth hormone releasing hormone. Growth hormone releasing hormone is going to go, I don't know why this image is like this orientation. I feel like anterior should always just be on the left, but let's say that anterior is going to be right here on the right side. So growth hormone releasing hormone stimulates the anterior pituitary, and then see that little H right there? That's human growth hormone, okay? Then human growth hormone is going to go off into the liver, and it's going to basically become insulin-like growth factor. And so that's going to help break down glycogen, allowing the release of glucose. You guys remember where glycogen is found? So liver is one. Where else do you find glycogen in your body? Huh? Muscles. Excellent. Great. And then blood glucose levels are going to go back up, are going to go down. And then if they continue to increase, then you might have hyperglycemia, and then it's going to inhibit growth hormone. And then the opposite is true. If you have really high blood glucose, that's going to release somatotropin or growth hormone inhibiting hormone. Sorry, somatostatin. Take that back. Cool. So let's move on. Go through all these. Cool. So this is another summary of all those different hormones that are associated with the anterior versus posterior. The only one that's a little bit different here, just make sure that you know that melanocyte stimulating hormone, melanocytes are going to be associated with that pars intermedia. Okay. All right. This is going to be the final one that we're going to go through. It's not a case presentation, but take a look at the optic nerves here, cranial nerve 2, right? So the cranial nerves are going to cross at the optic chiasm. Not all the fibers are going to cross, however. Some fibers are going to remain on the same side, whereas others are going to decussate and cross it at the optic chiasm. So here's the pituitary gland at the infundibulum, right? The pituitary gland is going to be directly posterior to the optic chiasm. Now, if you were to have a pituitary tumor, what do you think would happen? So you can follow these lines over here. That's going to be your field of vision. So which field of vision, lateral, peripheral, or central, which one would be affected by a pituitary adenoma? What do you guys think? Anyone want to take a guess? Both. We said both. Who thinks both? Who thinks only one of those? Which one do you think? Lateral. So peripheral vision loss. Does anyone think otherwise? So does everyone think peripheral? Yeah? Cool. Yeah, so peripheral vision loss. That's what's going to be associated with pituitary tumor. So here's your peripheral vision. So it's going to be red lines, right? So the red lines come in through here. They go down the middle, and those are the ones that cross over, okay, at the optic chiasm. So they go contralateral to the opposite side. Rock and roll. So here's a summary of all the different regions that the pituitary gland has effects on, okay? So it's going to affect your adrenals, muscles, bones, right? Think about like calcitonin. Well, sorry, that's from thyroid. I have to scratch that. So skin, melanocytes, thyroid, right? So thyroid stimulating hormone. Did I say calcitonin? G8, so growth hormone. And then testes and ovaries are going to be both FSH and LH. And then breasts are going to be associated with oxytocin, prolactin. And then ADH is going to be your kidneys. So several different organs in your body are going to be directed by the pituitary gland. So, any questions? Let's wrap it up with some quizzes. I have 8 questions that we can go through. So, what's up? Yeah, you should be able to. Is the link active on that? It's not. Okay, so if the link isn't active, that's good because that'll be for your later study, just as a reference. I will, if the link isn't active on the PDF, I'll upload those links on the announcements so you can have access to those. So it can help you like guide your study and whatnot. Okay. All right, so let's do it. Okay, let's do a head count here. So if I counted correctly, that's 51 of us today. Are you joining? No, you don't have to. So if I counted correctly, it would be 51. Once we get to 51, then we'll begin. All right, 2 more. Who are the slackers? All right, 1 more. I think. Did I count correctly? Is there still 1 more person trying to log in? You can raise your hand. Anyone else trying to log in? Are we all logged in? You're trying to log in. 52. Did you get in? Was that you? Okay, awesome. Slackers. Just kidding. All right, let's start. Like popcorn. All right. I think I need to make these questions harder. So, adeno hypophysis, perfect. Neurohypophysis is going to be posterior pituitary, right? Associated with what 2 hormones? And ADH. All right, next. And we'll go through each of these real quick as well, just to give a little bit of a recap from what we went over on Tuesday. Wow, that's across the board. Across the board. But most of you got it right, I think. 24, almost. It's almost half and half. It's almost half of you got that wrong. So glucose derived, there's no glucose derivatives, no glucose derived hormones. So the three major categories are going to be amino acids, right? So like T3, T4, things like melatonin is another example, epinephrine, norepinephrine. There's going to be peptide-derived. Do you guys remember some of the peptide-derived hormones? Take a guess. You guys remember? You guys remember what a peptide is? Just kidding. So peptide-derived, think insulin and glucagon. Those are going to be two good examples of peptide-derived hormones. And then lipid-derived. What are good examples of lipid-derived hormones? Steroids, excellent, yeah. So cholesterol is going to be kind of like the precursor. Some other examples of that would be like prostaglandins, leukotrienes, things like that, okay? You guys answered that one pretty quick, too. Maybe a little bit too quick. All right, so the majority of you guys got this one wrong. ADH and oxytocin. They're associated with two different areas in your diencephalon. What's the first area? Huh? Did you say hypothalamus? Excellent. So they're going to be produced in the hypothalamus, okay? Then they get stored where? Posterior pituitary, aka? Yeah, awesome, cool. Great. So make sure you know that, all right? Do we need any further clarification? No? Okay. Dude, those are killer boots. Is that snakeskin? Alligator, right? Snake? Okay. All right, most of you guys got this one correct. That was pretty easy. We just literally talked about it. So, what's the other one? Oxytocin is the other one. Antidiuretic hormone and oxytocin. Dang. Thyroid hormone release is directly stimulated by. So directly is the key word here because it's indirectly stimulated by this guy right here, right? Thyroid releasing hormone from your hypothalamus. Then it's going to be directly stimulated by thyroid stimulating hormone from the anterior pituitary. And then once it's released from the anterior pituitary, TSH is going to stimulate the ability for the thyroid to produce thyroid hormone. Most of which is going to be T4, some of which is going to be T3. That is the active form. Okay? You guys good on that? Does that make sense? Yeah? No? Does that make sense? Please tell me yes. Yeah? Okay, good. Just want to be sure because most of you got that wrong. It's definitely D. All right. Nobody picked D? Thought at least one of you would have done it as a joke. Anyways, so the most common form of intracellular communication is going to be paracrine. It's as simple as that. Just commit that to memory. Paracrine communication, that's going to be release to adjacent cells within the same tissue, right? Not to be confused with direct, which is going to be associated with gap junctions, like cell to cell, like they're directly attached to each other. And then endocrine is going to be release of hormones into the bloodstream, right? And carrier pigeons are just really cool. I don't know. Sorry. Two more. Awesome. Good. Cool. So not thyroid, right? So it's only going to be cortisol, sometimes aldosterone. Not always aldosterone, but sometimes. It's going to be mostly cortisol, and that's going to be primary adrenal insufficiency. Last question, and we're done. We're going to talk about this a lot next week. So if you don't know this just off the top of your head, don't worry. We'll talk about it next week. We briefly talked about adrenal glands this week, so we'll learn all the different layers of the adrenal cortex and the adrenal medulla. Cool. That's what I figured. It was going to be across the board. So the adrenal medulla is going to be associated with epinephrine, norepinephrine. The adrenal cortex is going to be sex, stress, and salt. Okay? So we'll talk about all those next week. Good job, guys. And I'll post those office hours so you guys can come up by and chat if you need any further clarification on anything. Otherwise, have a great weekend. See you next Tuesday.